Examination, we have to do the vitals and the basic ones. Important things for us is nutritional status, functional status, because all this have some factor to play in recovery of the patient. Okay. In general examination also, look for anemia, look for cyanosis, jaundice, pedal edema. So all these things are important again in the diagnosis making, but also in the planning of treatment also. Then we come to a systemic examination. Whatever be the diagnosis, I think respiratory system is very critical for us. I think in any trauma or any we did ACCC thing also. You'll realize that airway is very important to us. Airway for complications, for post-op recovery, respiratory system is very important. So do talk about respiratory system, evaluate the respiratory system. Cardiovascular system is also important in some high-risk groups, especially old age, especially some coexisting heart disease. Look for abdomen, liver, especially liver cell failure. And again, these things, some of these depends on what the diagnosis of the patient which you are going to operate for. Renal analysis, all this, every hospital has a guideline to do some basic test before everything. So I think one should always consult the institutional anesthesia team and their guideline. So that basically leads to PSC, and do take them seriously. Please do not think that anesthetists don't want to work and that's why they're writing so many investigations. All of them are very important for a good preparation. And I always think that it's like an external check on you. If you have missed something, your anesthesia friends will pick this up and will remind you that, okay, maybe we need to optimize this for a good recovery. So work as a team with them. Investigations will get like some routine blood investigations like hemogram, LFT, electrolytes, kidney function test, some coagulation profile testing. These are some various things apart from some other things like chest X-ray, ECG, echo if indicated, and PFT also if indicated, depends on age, depending on diagnosis. So these things are bare minimum, I think, for every case. Yeah, unless if the patient is a young person, has to go for a local surgery, like maybe hydrocele or hernia, you may not go through a battery of tests. But as per what we follow is more than 40 years, I think all these things have to be done in all cases, whatever be the indication. Now, many people talk about that if the patient is to be done under spinal anesthesia, we don't need a whole setup. But remember, whenever a clearance is given for anesthesia, it is for all kind of anesthesia. Because what if you're doing a surgery and suddenly there is some problem and there's a delay and you have to convert it into general anesthesia, you cannot say that patient was only fit for spinal anesthesia. So prepare the whole patient, whatever be the case, for general anesthesia, and then decide what kind of anesthesia you want to give. So that's what it is. Now, once you've done history examination, investigation, you come to preparation of the patient. You have now the diagnosis, which is validated. So there will be some legal and ethical factors, like you have to know the diagnosis properly. It has to be documented. You cannot go in for surgery without a proper diagnosis. You cannot presume the diagnosis. Even if sometimes we have to go where there are some 2-3 differentials, but that thing has to be documented and as well as has to be told to the patient that what is the aim, why are we going in, what's the need of the surgery, what you want to do, what's the proposal for what procedure you want to go do, and what complications can arise if you do the surgery or if you don't do the surgery. Both ways, you need the patient and the relatives should know about it, and the team also should know about it, that what are we going for. Likely outcome, other available options for the same thing. So in your hospital, in nearby areas, or wherever, I think it should be given as a choice. So these legal and ethical matters are very important. Many of the centers may take the consent process very lightly, that it's just a paper to be signed. No, I think it's a proper process. So please take it seriously. Patient has to be put NPO, and I think I have seen that many centers follow different protocols. What I would advise you, because the things keep changing, that the guidelines keep changing, you have to follow the latest published guidelines and as local as possible. If you have a guideline at your hospital, please follow that. If you have a state guidelines, follow that. If you have a country guideline, follow that. If none of this is available, then follow international guidelines. Okay. So in NPO, what we follow is there should be the patient can take clear liquids till 2 hours before the surgery. In the immediate 2 hours, patient will not be taking anything. It's like nil per oral for 2 hours. Patient can have a light meal 6 hours before the surgery, and patient can have a proper meal 8 hours before the surgery. Uh, Another thing which I want to highlight here is, like, for example, uh, what I see, like, there are, let's say, 4 patients to be operated in whole day. What typically order is given that everybody will be nil per oral one night before. So the person who is to be taken up, let's say at 8 o'clock in OT, for that person still is okay to that person can be NPO for, let's say, around 8 hours, 10 hours. But imagine the person will be taken in for a surgery at 2 o'clock. For this person, it's like uh, around 16 hours, 17 hours, sometimes NPO status becomes. So, which is very difficult. Now, what happens is the blood sugar starts going down after 4 hours, after 6 hours. And the counter insulin hormones like adrenaline, like glucagon, they start rising in body. So the sugar goes down, and then there is a surge of counter hormones, which are ADR and all stress hormones. They start rising. Now they will again cause hyperglycemia. And this is not increasing stress hormones and increasing hyperglycemia is not good for outcomes. That's why too much of fasting is not good for patient. Patient already is undergoing a stress. Now we don't have to give a stress of fasting. Okay. So remember, give them clear liquids. And what we also recommend is, maybe in this clear liquid, you can have some glucose added. So just powder glucose so that it remains clear liquid. The transit time is fast. You can have 50 grams of glucose in 1 liter of water. You can ask them to have it till 2 hours before. Okay, patient can take in the morning of surgery, like maybe the surgery is at 8 o'clock. These people can start taking between 4 to 6, especially for people who are to be posted in afternoon. In morning, they should have some light breakfast, and they can have liquids in their meals. Okay, so this is very important of how to manage the food before surgery. Okay, glucose loading we have talked about. Now, another important thing is about part preparation, whether to shave, whether to clip, whether not to do anything. Again, this is subjective thing. First of all, if the part is not directly involved, you don't need to prepare the whole body. Okay. So if you're going to give incision in subcostal area, maybe some clearing needs to be done at that part, especially which is there in the draped area. As per recommendations, there should be no rash or wound in the operating site. Clipping is preferred. Shaving is strict no these days. Okay, so, because what happens is, I'll tell you the theory. Why we do part preparation? Because we believe that there will be some bacteria will be in the hair follicles. The cleaning of skin is not very good if the hairs are there. But what happens if you shave? You'll always have some cut marks. Okay. Now, these cut marks will cause blood debris, and that will attract more bacteria. So rather, what you are trying to prevent, now you are facilitating that. So that is why shaving is strict no. If you have to shave, it has to be done on table so that bacteria don't get a chance to colonize during or before the surgery. So if you want to do shaving, there's no other option, there's no clipping available or whatever, then do it on table. Clipping can be done 1 night before. That is the guideline. If too much is there and very, like, for example, most of the ladies will not have that too much of hair, or the person is not too hairy, you can even avoid shaving. or clipping by any means. If it is not hampering your site, and you think that you can do a good job even without shaving. So unnecessary, it's not like everybody has to go through. Now, another thing is many people use epilation creams. That also has shown to cause a lot of allergic reactions and rashes. So typically we advise not to use it. Clipping is a very good, I think. Just have a shaver in your ward and just clip it the side, and you'll be okay. And for emergency surgeries, if you don't have time, I think you can shave on the table. When the patient is anesthetized, you can quickly shave it and do the surgery. Bath is recommended. I think what we recommend generally, if the weather allows, can have a good bath one day before and on the morning of surgery also. Antiseptic solution, normal soap is whatever is good. It should be a good bath, especially at the site. Pre-op drugs. For the bath, I think if the operating site involves, like, say, lower limbs, perineum, which are as such not very clean areas in the person, then you can advise a good scrub solution like Vitarine scrub or something like that, and patient can have a bath with that. That is effective. Some pre-op drugs are there. I think you should always consult your anesthesia team or other concerned team for what drugs to be allowed. But a general guidelines, we do give prokinetics and antiemetics, anti-anxiety, antibiotics, again, as per recommendations. DVD prophylaxis, again, as per recommendation, we'll talk about it, and always consult the anesthesia team. WHO checklist, I'm sure you all are aware of WHO checklist. So what ideally in pre-op period, the main purpose of WHO checklist is that the whole team should be aware of what you're going to do. Now, the team should meet before the OT, before the patient is wheeled in, into the OR. Team should recheck the diagnosis, recheck what's the plan, recheck whether everything is available or not. And this should happen at multiple times. WHO checklist only talks about the operation period and perioperative period. But I think this discussion should happen when the patient is in ward and much before, maybe a day before or 2 days before the operating list is decided. And the whole team should know, and also the patient and the relative should know that what is going to be the plan. And if there is a need to consult other departments, if they also have a role, for example, pathologist, for example, radiologist, they should also be consulted in this. You need to give antibiotics 30 to 60 minutes prior to the incision. Now, this is the recommendation. This is what is followed. It need not be given 2 hours, 3 hours before, because again, what we want is the peak of antibiotic concentration in blood should be when you make the incision or just after that. So that is why the best time is when the patient is taken and is being induced, so that then you inject it, so that while you drape, while you clean the patient, the antibiotic rises in the blood and it is there to work when it is needed. So that is a time. Repeat if the patient or the surgery extends beyond 2 half-lives of the drug. Mostly we recommend that if any surgery is beyond 2 hours, you repeat one more dose of it. Okay. No antibiotic prophylaxis is to be given for clean surgeries, like class 1 surgeries. For example, you're doing hernia, you're doing breast lump excision, fibroadenomas, generally nothing is required. For class 2, class 3 surgeries, you have to give 1 dose of broad spectrum IV antibiotics before the surgery. And in clean cases, there's no contamination, there is no need to continue it in post-op period. Whereas for class 4 or grossly infected cases, antibiotics should be going on before and after the surgery. I think this is emphasized a lot, and just follow this. It works. Like DVD prophylaxis is another important thing which will prevent a lot of unnecessary morbidity and mortality if you follow it. So as a rule, if the surgery time is more than 45 minutes, If it is a cancer surgery, if it requires immobilization, I think DVT prophylaxis should be started. There are apps available where you can just put in the profile of the person. You don't need to remember the whole table. There are apps available on your mobile. You just enter the patient detail. It will tell you what are the recommended guidelines and whether. So in some cases, the low risk patients, we have to just ask for early ambulation as soon as possible. Patient should be walked and encourage them to walk. It is mainly for less than 40 years, no risk factors, minor surgeries. Any patient which is undergoing a major surgery and has some risk factors but still is less than 40 years is a category 2. We use a mechanical prophylaxis mostly. If the patient doesn't have too much of bleeding risk, you can start perioperative low molecular weight heparin or ultrafiltrated fractionated heparin. Again, similarly, class 3, class 4, major surgeries more than 40 years, obesity, cancer surgeries, you have to give both mechanical as well as heparin. Now, heparin, again, if there's no bleeding risk, you can start before the surgery. But if there's a risk of bleeding, then you start after 24 hours or whenever you feel that now there is no risk of bleeding. If very high risk, then you don't have much option. You have to start extended prophylaxis, which may be before and after. It is for major cancer surgeries, ortho, trauma, ICU. As per rule, I think you should remember that mechanical prophylaxis should be there in all cases because we say 45 minutes. The guidelines is 45 minutes is the major surgery definition. So almost all the surgery which you will do, even like gallbladder surgeries, ventral hernias, PEPs, most of them will come under this category. So it's always should be a protocol. And I think it's easier to remember that in all cases we will be using DVT pumps rather than we have to think about that which cases to use and which not. Okay, so remember this. We have talked about this, like in low molecular weight and ultrafractionated and fondaparinux, whatever is available. Again, please check what is the guideline followed at your institution. Not having a guideline is not, I think, acceptable. Please talk to your team, talk to the institution, and have a guideline that what we are giving. Okay, there are various options are available, and some all have some good advantages, some disadvantages. Okay, we use low molecular weight heparin mostly, so that can be used. Then there are some coexisting conditions which needs to be optimized. Like, for example, there are some drugs which has to be given, like hypertension, which is very common these days. Almost every second person is a hypertensive on drugs, controlled or not controlled. So first of all, the thing is we have to have a controlled hypertension. There's no business of doing an elective surgery in an uncontrolled hypertension. If it is a emergency case, then the whole story is different. But if the hypertension is there, there's some drugs which is safe to continue in perioperative period, like calcium channel blockers, alpha blockers, and beta blockers. They can be safe, and if their patient is on these, they can be continued. Whereas if the patient is on ACE inhibitors or diuretics, because these both are diuretics, so both causes hypotension and electrolyte imbalance. So these are not to be continued on the morning of surgery. So you have to be stopped before the surgery. Maybe you can shift them on some other drugs like calcium channel blocker and in the perioperative period. And as soon as the surgery is over and patient is stable, you can shift back to the old regime of drugs. Again, consult your medical friends who can help you in this adjustment of doses and drugs. Then diabetes mellitus, again, an important thing. In this also, remember, the drugs, the oral hypoglycemic drugs are generally not indicated. So we have to stop them, convert the patient into insulin, because insulin is a more reliable and titrable drug. We can adjust the dose and accordingly the glucose also will, and especially the regular insulin, which is a short-acting insulin. Now, we want a slight level of hyperglycemia in perioperative period. Okay, that is why dose slightly we reduce. So either it is 1/3 or 2/3 of the main dose, okay, and which is what we want. So this is what we do for diabetes mellitus. Again, consulting with your medicine or endocrinology friends is important. Cardiac medication, if the person is on statins, is to be allowed. Continued aspirin is to be continued, whereas any patient who is on clopidogrel has to be stopped at least 5 to 7 days before. Warfarin has to be stopped. You can bridge it on low molecular weight heparin, which can be continued even on the day around 2-3 days before the surgery. You can continue, because again, it's a very short acting thing. So in the morning of surgery also you can stop, okay, to 24 hours before. Low molecular weight can be stopped, and then started after 48 hours. Again, depends on what is the risk of bleeding in this person. Then there's a long list of other diseases which require some specific preparation. Now, this part would have been covered while discussing, let's say, thyroid disorders or pheochromocytomas and other things. We'll quickly run through this. So, but before going to elective surgery, I want to talk about how to prepare emergency cases. Now, very less window is there generally in emergency cases, but there are some things which if you try to do, you will have a good outcomes. Now, emergency cases can be trauma or non-trauma. And, in trauma, we follow ABCDE. So we do a ABCD evaluation, and the recommendation is to give tranexamic acid, correct metabolic acidosis. There is no point undergoing a surgery when the patient is in metabolic acidosis. Even if you have to, please activate what is called as the damage control surgery protocol. That means you have to do very quick in, quick out procedure, as short as possible. Only life-saving surgery, only life-saving part or maneuvers have to be done. IV crystalloids is to be given. Fluid or blood as soon as possible you give, and correct electrolyte imbalance. Remember, the main killers are hypothermia, hypotension, and hypoxia. So 3 hypos you have to manage: hypothermia, hypotension or shock, or hypoxia. So this needs to be corrected to the best possible level before you take in the patient. And then you need to have labs of all these things at least. So you need to have some ABG, you need to have a PTINR, electrolyte, hemogram. Only thing is, if the patient is in a severe shock condition and you think that active bleeding is the cause. But very often patients would give you some window to resuscitate them. Do not rush in these patients, because the more you will stabilize the patient before taking the patient in, the better would be the outcome in these cases. Non-trauma, generally what we see is perforations, obstructions, bowel ischemias, and appendicitis and other things. In these cases, again, you need to do a basic assessment, history and examination, try to have some idea of what is going on so that accordingly you plan it. Do adequate fluid resuscitation. Now, this is non-trauma, so it will give you a good chance. Many times we see that we have seen a bad outcome because the patient was not properly resuscitated and taken in OT. That heroic rush to push the patient in and operate as soon as possible generally is not very helpful. Now we understand the physiology much better. It's always like resuscitation is a very important part. So resuscitate, make sure there's a good urine output of at least more than 0.5 ml per kg per hour. The mean arterial pressure is more than 65, and electrolyte, dextrose, and pH corrections is done. Then you take it in. Now, let's say if you have a patient of perforation peritonitis, the whole abdomen is distended with fecal matter or oblique pus, patient but is not doing well, urine output is not there, there's severe acidosis and all that. I would suggest that you put drains in this patient and then continue resuscitation. As soon as you put the drains, the pressure in the abdominal compartment will reduce. Patient's shock state might improve, and patient will show some improvement. And then you can go in and operate in a second setting. So these kind of maneuvers will help you avoid. It is also kind of a damage control strategy when you do the decontamination only. Rise tube drainage also will help you in decompressing and prevent, and also it will tell you about what kind of third space loss is there, what kind of obstruction is going on. Put Foley's, monitor urine output, see the renal status, whether urine output is there or not. Patient if is in sepsis, give antibiotics, give send blood cultures, vasopressors, and ventilatory support. All this is important. If now let's come to some specific surgeries. For example, colon. We talk a lot about preparation of bowel in surgeries. Now, preparation is indicated. When we say preparation means we need to reduce the organism load, especially in a when it's an obstruction condition. So mainly what we need is an antibiotic control rather than the mechanical preparation. In today's world, mechanical preparation is to be avoided as far as possible, because the thing is that with mechanical preparation, you also are removing the normal commensal bacteria, which are good bacteria basically. So you're also killing them. These good bacteria, they help fight the pathogenic bacteria. So if you are destroying them, then it's not a good outcome, and generally the prognosis or the outcome of these patients is not very good in terms of infection also. So that is why if there is a need, if it's a must, like you have to do anastomosis at that site, you need a mechanical prep of that. The indications, what you can try is giving enemas, so that the distal bowel, which is fecal matter, which is loaded, can be cleaned. Try to avoid mechanical bowel preparation of the small bowel and that part. PG can be used if it is indicated, but typically we will not recommend doing this. Oral antibiotics and IV antibiotics have to be given. Generally, they are started around a minimum 24 hours before, but also can be started 48 hours before. Orally, we have to give a drug which will remain in the lumen. So neomycin is a very good drug for that matter. Also, norfloxacin is also a good drug which will remain in the gut and not be absorbed systemically. Systemically, you can give antibiotics as per the local antibiogram. So you can give IV antibiotic as well as oral antibiotics at least 24 hours before the surgery. So MBP is not very effective. Mainly antibiotics is what is needed. This is very important, I think. Marking stoma, we all think that, okay, in this case, maybe we'll require stoma. And then in the surgery, after the surgery is done, then we are thinking of, okay, where should we bring out the stoma? Whereas ideally, it should be marked before the surgery, and it should be marked before the surgery when the patient is standing, sitting, and in different postures. The idea is that patient should be able to manage their own stomas. Okay, so in different positions, what we ask them is to see whether they are able to, look at it, inspect the stoma, change the bag if needed, on their own, so that they're not dependent on others. If, let's say, you're putting a stoma in a position where they're not able to see it, if, let's say, there's an obese patient and you make the stoma way down, they'll not be able to see if even if there is some problem is happening. So that is why marking beforehand is important. Okay, so and we know the basic rules that it should be on the rectus abdominis lateral border, it should be away from bony prominences, it should be having a flat area where a bag can be applied. All that thing is there, but remember one thing: it has to be marked before the patient is anesthetized. That is important. Some people also do a colonoscopic tattooing because sometimes when the lesion is inside the lumen, from outside it is very difficult, especially in the laparoscopic surgeries. It is difficult to identify what site is this the thing and where from till where we have to take the margins. So sometimes in colonoscopically, we mark it while doing a colonoscopy. So we around 3 to 5 centimeters distal to the distal most part of the growth, we mark at three sites. Why three sites? Because you don't know which part will be the visible part of that bowel of that, maybe let's say especially in the mobile part. So it's if it's the multiple parts, wherever you are whenever you are inspecting the bowel, at least some tattooing might be visible. So you inject some ink, which will be visible from the serosal side also. So this is what is needed, and especially for early lesions, especially for small polyps or early cancers. So this is to be done. Stenting, there was a lot of stress about the need of preoperative stenting to avoid ureteric injury while doing the bowel resection or mobilization. So while ascending colon or descending colon on either side. But nowadays it is said that it is not that much needed unless there is a direct invasion of ureter. Pre-op stenting may or may not be done. It's not a must. Again, it's an individual choice. If you give, at least in open surgery, we have seen it becomes very useful. Even in lab, if through the instrument also, you'll be able to feel the stent, so it becomes easy in those conditions. But if there is the imaging is indicative that the ureter is involved, you can put a stent uh, uh, before. We have talked about carbohydrate loading, but I am again emphasizing, especially for it was recommended mainly for under ERAS protocol. It was mainly for colonic surgeries, but nowadays it can be used in other surgeries as well. So what is done is 6 hours before is not allowed to eat anything solid, and till 2 hours before surgery, we give them liquid, which is in form of a carbohydrate solution, which generally shows that patient have less hyperglycemia and less high levels of stress hormones, and so the recovery electrolyte imbalance is better in postoperative period. Avoid prolonged fasting. We have emphasized it earlier. Again, we are emphasizing it here. We talked about VTE, but in colonic surgery, it is very important that we have to put the patient on mechanical. Is sure, has to be done in all, and pharmacological if needed. So this is what it is. Whenever you have a cancer patient, I think you need to involve multidisciplinary team, and it should have surgeon, anesthetists, physiotherapists, your medical oncologist, radiotherapist. Everybody should be there part so that you have a common plan, and not just a surgery plan, but the long-term plan also. Patient should be adequately explained. It's important. Nutrition support is important because most of these people have lost weight, they're anorexic, they're not eating well. So we need to build this patient nutritionally also. Uh, DVT prophylaxis is a must, and try to correct whatever you can, like anemia, cardiac conditions, and all that. There should be a minimum gap of 3 to 4 weeks before the last chemotherapy and surgery. So what happens is, uh, after giving chemotherapy, the TLC, WBC, and the red blood cells also, they start declining, and they dip. The maximum dip happens 1 week after it, and then it starts recovering slowly. So to have this adequate recovery of the body's immunity recovery process, it requires at least 3 weeks. So that's why 3 to 4 weeks we need to wait after chemotherapy. Okay, so that is important. Do get a hemogram done, because again chemotherapy destroys these cells also. So make sure that they have a good level. Sometimes they will need things like blood, but more than that blood, we prefer giving GM-CSF for WBC, and erythropoietin for RBC's growth. Platelets, do ensure it is okay. TLC, you should ensure, and then do an organ specific evaluation, like you do a pulmonary test if you have given some drugs which cause pulmonary fibrosis, like bleomycin, and all, do get a pulmonary function test done. If the patient, if the drugs have effect on heart, do evaluate the cardiac condition, do have a renal evaluation almost in all drugs it is needed, and hepatic evaluation almost in all drugs it is needed. So make sure when the patient was on chemotherapy, there's a specific evaluation of all these also. Many times you'll get a jaundice patient. So in jaundice patient, the main problem is that they have a coagulopathy, they have volume depletion, and their immunity is low. So these three things have to be kept in mind. So correct coagulopathy, start vitamin K. Remember, vitamin K will take at least 5 to 7 days to have an effect. So do not think that you're just given a vitamin K injection and patient is okay. If there is some urgent need of surgery, then use FFP or fresh frozen plasma. Generally, these patients again are nutritionally weak, so build that up. IV hydration is important, IV fluids is important, and antibiotic prophylaxis is important because these are generally these patients are immunosuppressed. Drainage, like for example, we get a patient who is deeply jaundiced. Now, the question is whether to get a pre-op stenting or not. Pre-op stenting can be avoided unless patient shows signs of sepsis or cholangitis, or patient is having severe malnutrition, or patient are debilitated. This thing, broadly, if the bilirubin is more than 20, then maybe it's a condition of stenting. Otherwise, you can avoid stenting unless there is cholangitis or patient is not prepared for surgery immediately. Like you think that because of condition of the patient, it will take some time for the patient to be ready for surgery, then maybe you can undergo a stenting. Otherwise, you can avoid it. So bariatric surgery is another very common surgeries which you would be seeing in your practice. So generally, bariatric surgery, it's not just a surgery where you go in and put a stapler in the bowel. It is a metabolic disease. So when we say metabolic disease means there are a lot of metabolic problems. These patients are generally diabetic. These patients are hypertensive. These patients have cardiac conditions. These patients have risk for deep venous thrombosis. So you have to plan for all these things. So you have to know that HbA1c is okay. You have to know that the blood pressure is less than 140/90. You have to have a psychological evaluation also, because a lot of time we see that the failure happens because the patient starts eating again. And surgery is not just the treatment. Surgery is one of the treatment of these people. You have to evaluate OSA and CPAP and some therapies needed. All that is needed. You have to modify the diet. You have to bring them to very low calorie diet before the surgery also. And similarly, we talk about geriatric patients. We get a lot of geriatric patients. As the life expectancy is increasing year by year, you would be seeing, I think, more geriatric patients in your practice. So you need to know that there's a proper assessment happens, because they have a lot of medical diseases, there are a lot of neurological diseases, a lot of functional problems. The walking is not proper. The frailty is there. The reserves are very low. There even intravascular volume or body fluid is also less. So all that requires a proper evaluation.